session in which we are going to focus predominantly in terms of technological advances with regards to pediatric endocrinology. And we know pediatric endocrinology is one branch which has witnessed a lot of changes. And often when we talk about technology, we traditionally have been talking about how new devices have come up, or whether you've got a new way of giving glucose monitoring, or you're doing some new insulin. But what we're talking about technology today is to how these protocols are properly implemented at the last point. And this is what the aim is, to develop point of care tools which can help out in terms of improving technology. So our aim has been to develop tools which can be implemented in different regions, across resource settings, across the different exposure in that regard. And we'll be focusing about how these point of care tools can help guide 5 key disorders in the form of growth, puberty, thyroid, glucose, and electrolyte disorders, and how we can individually look at in terms of evaluation, assessment, and management of these disorders. iPedendo basically is a way in which we want to go out in terms of developing tools which will help in terms of evaluation of these key disorders using a very novel approach of mobile application, which has been there now for some time, but we have been keep on editing them in terms of improvement. So our work with regards to pediatric endocrinology actually started maybe around 13-14 years ago, when we started with workshops on different disorders. This was much early. Then we gradually developed those workshops into 6 modules, which were in the form of a practical pediatric endocrine course, which we conducted across the country. Then we realized it's going to be difficult to keep on conducting programs in that extent. So we went on to social media in terms of YouTube, in which large number of videos were available. We started an on-site fellowship around 6 years ago, and till date we have got 11 fellows who have joined who have done or are doing the clinical fellowship in that regards. Then we realized that we also need to spread out the message, and that led to the development of MedEClasses around 5 years ago, which is a portal dedicated towards improvement in pediatric endocrinology, which then further led to the publication of multiple books, and then the mobile application. And we are going forward in terms of these regards, and we'll talk about the subsequent developments which are happening in that regards. One of our important interventions is the e-learning tool, which is in the form of a YouTube channel, which has got extensive resources. Pretty much everything about pediatric endocrinology is there, and it's quite widely viewed across the globe as well. We have got our website, learning.growsociety.in, which provides validated courses with regards to various aspects of pediatric endocrinology, and they range from small courses like growth, puberty, to more specific and larger courses in the form of the fellowship programs, as well as the pediatric endocrinology for postgraduates and other programs in the form of, which are available on an online or an online on-site hybrid model. We have got 3 key books which focus from practical approach to basic to advanced pediatric endocrinology, which provide a comprehensive understanding of these tools. But what we realize essentially is that with all the knowledge and resource, ultimately, when you are seeing the patient for the first time, you may get puzzled in terms of how to implement all the knowledge, and therein the confidence becomes a bit difficult. And whatever you remember will not always be a sort of a standard of care, and often that results in errors. So there is a need in which we really combine between the knowledge which is there in terms of available, in terms of resources, in terms of guidelines, in terms of algorithms, with what we really practice in that regard. So how do we do that? There are multiple factors required. You need to decide about which tests to order. You need to look at the interpretation of each and every clinical sign, as well as the investigations. You have to then decide about what treatment is there, and that's why you need to have a very comprehensive approach on that. So we tried to develop a solution which can help out in all of these things in terms of analyzing the symptoms, interpreting the key parameters, advising investigations, then comprehensively looking out on investigations and deciding about that treatment. And we realized that the most powerful device there would be a mobile application, because if you think of it, mobile app is available to everybody, and all of us keep carrying that mobile everywhere. If you talk about, let's say, a web portal based approach, it requires at least an office setting. So this can be used across settings, very easy to do, and you just develop and can be used across the globe as well, providing same standard of care at different regions in that perspective. So this led to the development of our mobile application, which was developed a few years ago, which is in fact the most downloaded endocrinology app all across the globe, with number of installs and a lot of publication that we have done in that regards. The way we structured this is to develop pathways which provide us guideline-based approach in an algorithmic manner. You have to question and answer, and you will get the final diagnosis in that regards. There are approach pathways and management pathways. So they will guide stepwise management and approach. Suppose you want to know about hyperkalemia, it will ask about specific conditions, and then we'll go in terms of diagnosis. More recently, we move more towards interpreters, which are instantaneous, because now the general tendency, you don't want to go and wait for a long time. So you just put in some data, like in the form of a thyroid interpreter, you interpret the thyroid results and you get the results automatically. Similarly, the bone age interpreter, which has been published and validated, which provides a wide, and we'll discuss about this tool as well as more disease-oriented interpreters, in which based upon your symptoms, we will then decide about what workup is required and how do you reach a particular diagnosis. So we've got multiple interpreters like puberty interpreter, obesity interpreter, DSD interpreter, which really guides, and we are working on a combined electrolyte, calcium, and glucose interpreter, which is going to help out in that perspective. Now, once you order a test, you need to really understand the intricacies of when to do, how to interpret, and age-related. So, of course, we don't have all the information, and that's why we have put it every detail in the diagnostic section and information about every drug in the therapeutic section. So within the app, you can actually, once the patient comes to you, decide about what investigations you want to do. You can then decide about how to send and all the information is there. Once the results get in, you can interpret those results, then you can prescribe and you can know about the particular drugs as well. So we sincerely hope that this endocrinology application is the bridge between the evidence base and the practice. So this is expected to result in evidence-based practice, and we already have publications which have shown its improvement in care in terms of decay, growth, and bone age assessment. And we are working in terms of validation for many more disorders like diabetes, DSD, puberty, obesity, thyroid, and it could be because of XX-DSD, which is basically a scenario of acts of commission in which you have got more androgens which are there. In this scenario, you will have Mullerian structure, but you will not have any gonads. XX-DSD can be because of androgen excess coming from the adrenal. The most common cause will be congenital adrenal hyperplasia, and you may also have rarely ovarian etiology because of aromatase. Rarely you can have gonadal dysgenesis. You can have a XY-DSD, which is basically an act of omission in which either you have no gonads, you have got no testis, you have no testosterone, you have got no testosterone receptor, and that will cause a XY dysgenesis. In this scenario, you will have gonads, but you will not have Mullerian structure. So you will have dysgenesis of the gonad which are there, or you may have an impaired DHT response because of a number of steroidogenic defects. XY-DSD is much more complicated as compared to XX-DSD. And then you can have a combination of over-testicular DSD in which you will have both gonads and Mullerian structures together. The questions are, is it DSD? How do you classify, and what's the cause in that perspective? So just look at two things, gonads and Mullerian structure. If you have only Mullerian structures, no gonads, this is XX-DSD. If you have got gonads and no Mullerian structure, it means gonad is working. This is XY-DSD. If you have got both, it means a over-testicular or rarely a AMH resistant state. If you have got nothing, which means that there is either an intra-abdominal testis or the testis was damaged at some point of time, but they did produce AMH, which caused regression of the Mullerian structure in that regard. So approach is look at palpable gonads. If the palpable gonads are not there, look at Mullerian structure which are present. It's most likely a XX-DSD. Look at 17-OHP levels. If it's high, it's CAH. If it's normal, it's more likely to be aromatase or dysgenesis. If your palpable gonads are present and Mullerian structures are also present, then this is complicated. This could be gonadal dysgenesis or this could be anorchia. While if the levels of AMH are high, this is AMH resistance. If you have a scenario of palpable gonads being present and Mullerian structures basically are absent either way, in that scenario, you start doing a testosterone levels. If testosterone is low, look at salt status, which will classify into salt wasting forms, which is side chain cleavage 3-beta-HSD or hypertensive variants like 17-hydroxylase deficiency, a normal salt status like LHCG receptor defect or 17-beta-HSD, and finally a high level where DHT will classify into 5-alpha reductase and AIS. The evaluation of XY DSD is often very complicated, and now we do have more of genetic tools. So the basic crux is to look at the testis and the Mullerian structure. Mullerian structure without testis, this is XX, 90% 21 hydroxylase deficiency, get a 17 OHP. If normal, think of other things like aromatase or 11. Mullerian structure absent, gonads there or not, doesn't matter. This is XY DSD. Look at testo, low testo, look at sodium potassium, you will get a hypertensive variant 17 hydroxylase, a hypotensive variant 3 beta or side chain cleavage, or if it's normal, this is most likely 17 beta HSD or LHCG receptor defect. High testo, it's either a problem of 5 alpha or resistance action. And finally, if both are present, go for AMH in that regard. So we now have a day 3 child, who has Prader stage 4 with no gonads. So what's your next step?
Yes, so this looks like an XX DSD, no palpable gonads, uterus is present. With such degree of virilization, one needs to look at 17 OHP levels and rule out CA.
So we have developed a DSD interpreter based upon your primary inputs of gonadal structure. It will basically ask a 17 OHP level, which in this case was found to be very, very high. And there was also hyponatremia as well as hyperkalemia. So what are we getting out here? That this is a 21 hydroxylase deficiency. So this was a classical case. Now this is a day 3 child with DSD, Prader stage 4, no gonads again present. Now what are you thinking here?
So again, we need to look at whether Mullerian structures were present or not to basically.
So uterus is present. So this was labeled as 46. XX. So again, in this case, 17 OHP is marginally elevated. Do you think this is CH?
No, sir. With CAH, 17 OHP levels are much higher. One needs to look at the history of maternal virilization, look at the salt status in this child. That will probably help guide.
So this child, as you said, has no palpable gonad Mullerian structure is there. There is maternal virilization, which is present. 17 OHP is marginal. Sodium potassium is normal. So this is unlikely to be CAH. Think of aromatase deficiency. So this DSD interpreter is really one of the evolved, I would say, algorithm which really goes deep in terms of diagnosis and will help everybody across the thing to go at the right diagnosis in that scenario. So this was aromatase deficiency. Day 14 child with DSD who has got bilateral gonads but no uterus. So this is X1. How will you go further?
So in this setting, the next thing to look at is the salt status and the testosterone DHT levels.
So in this case, you would say that, as you said, we look at sodium. Sodium here is basically on the lower side. There is hyponatremia. There is hyperkalemia. So what do you think are we dealing with?
Yeah, so one of the salt wasting varieties may be something like based on testo levels. So testo is not so low, so more like 3 beta HSD.
So this is classically 3 beta HSD. So we can actually classify based upon these parameters as to what we are looking at. So testo was high, not low at least. There was hyponatremia, hyperkalemia. This was a 3 beta HSD. Day 14 child. Again, now what's typical that you get on the image here?
What we see here is an asymmetric genitalia. So one side looks like scrotum, the other side appears more like a labia.
Yeah. And there was uterus on one side, testis on the other. So this is more likely a complicated picture. So we are saying both are present and you have asymmetrical genitalia. You're basically dealing with most likely a over-testicular DSD as a possibility. So again, the applications will help you out in that regard. So this is available in the form of our app, which has got so many approach pathways, management pathways, which help you guide specific management, and you can download it through both Android and iOS stores. We also have the various courses for different groups, from the postgraduates to the fellows to the pediatricians, and we have got specific courses for the pediatricians as well as postgraduates in that regards. And of course, this mobile application will help you reach a diagnosis.